All right, welcome to MTV Studios. I'm Kat Hurd. I'm here with Tim Moran. Tim, you're with Heal Clinical,
Yep.
founder.
Yep.
Give us the background. Tell us about Heal Clinical.
Heal Clinical started, my nephew passed away in 2020. Unfortunately, many people have had that experience. All-state basketball player, became addicted to narcotics, opiates, and then fortunately got off of them for a while. Hurt his back again, like many patients had in his cabinet drawer, medicine cabinet drawer, had the pills from before. Took too many because his tolerance had gone down. He overdosed. What was disturbing and the reason Heal got started is it was fixable because he did have naloxone in the nightstand drawer, and we found that upon clearing out the home. And I said, well, this is fixable. There's got to be a way to do it. So that's where Heal Clinical started.
Wow. I'm so sorry to hear about your loss, but I love that you've turned a moment of loss and obviously intense grief into a moment of change for this space, because the opioid epidemic, unfortunately, is not going away. I've spent 15 years in interventional pain, working inside of those pain clinics, and I've seen it firsthand and the challenge for patients. So tell us, how does Heal Clinical create solutions?
Great. So my background is not medical, so for that, I appreciate all the work this conference does and all the individuals that work in the industry. What we've done is build an educational system that also has an assessment component. So we work with the doctors where we know their pain buttons are. Right? Doctors don't bill for educational because, one, they don't have time, two, they don't know what they can bill on, or three, they just they struggle with how to do it, or the reporting, the consistency. So at Heal Clinical, we provide a tablet-based solution, does the education from the lobby while the patient's waiting for the exam. The information is then transferred into any EMR system. At that point, the patient is talking to the doctor or the provider in the exam room, and they know what questions are at risk. So at that point, instead of having a discussion of, hey, how you doing, Kat? How you feeling today? The doctor really can get down to the gist of it. Why are you sharing your pain medication or other items that may come up in the assessment and or risk? And so they then can log that. It's a billable code. So there is economic value to the doctors. And that's really what our program is. It takes 30 seconds. So the workflow is my biggest concern because the front desk is the one that controls
Of course.
the office. So we want to make sure that performance is very quick and that the doctor has actionable, essential data to interact with their patients.
That's great. So talk me, you mentioned education, right? So talk me through what the education process on the tablet is.
Great.
In addition to the assessment, it sounds like that exists.
Yeah, so the doctors run it, the pain doctors, successful pain doctors that we work with currently run it every single month, whether or not they get reimbursed. You don't get reimbursed every month for this type of care. The benefit is it changes every single month. So the test is never the same. So what the education questions came out of a 2013 study, of course, done by Purdue Pharma, which is the villain in most of the stories. But the Ohio State University did the study. We have now had 4 years, several tens of thousands of patients go through the process. So we probably have a bank of questions close to about 600. And the output is very simple. There's an opiate education piece. There's a medication management piece, normally where the doctor is communicating most effectively with the patient.
Yeah.
And then there's the AEP, the Heal Clinical AEP, Adverse Event Plan. Do you know what Narcan is? Do you have it? Have you told your family or social circle about it? Do they know where it is, and do they know how to administer it? So that's really the actionable piece that comes out of it. Yeah. But we've seen great statistical numbers, reductions of benzoids, increase in Narcan, reduction in sharing of medications. Here's the most staggering stat. 45% of patients did not know they were taking an opiate.
I'm shocked, but also not shocked because of the proximity I've had to those patients. These patients take what's prescribed to them and don't often understand. Not that they haven't been educated, but sometimes it's not absorbed. So how does Heal Clinical bridge that gap if they aren't aware?
Yeah, so when the patient comes in, every time they come into a chronic pain management system or office or clinic, they would be handed the tablet with their name and date of birth. Mm-hmm. They would interact with the data, the questions that are there. There may be a DAST, an OURT, substance use disorder test, and those would vary depending on what's going on with the questions. and how they're answering. And then that data is then transferred to the doctor. So you're looking at maybe 5 to 6 minutes in the lobby. That's normal wait time.
Yeah.
If we have to email it to the front desk, because some of the EMR systems are a little slow to give us the direct messaging information, the front desk is looking at about 30 seconds to put that into the EMR system. So the doctor has that information in the exam room. And it really just kind of cuts through the noise and allows us to have a meaningful conversation.
Yeah, that's great. Are you also with that? Is there an outcomes component or a follow-up component that then you're feeding forward into the office?
That's a great question. And honestly, no, right? We believe that doctors are capable and providers are capable of the outputs. They just don't have the essential information to make those or have those discussions. So we're an in-clinic solution that allows the doctor to have garner and gather essential patient information, and then have a meaningful discussion in the exam room instead of, hey, Kat, how you doing today? How's it been? It's really a meaningful discussion because they have the risk outputs first.
Yeah, and I imagine it also has to both condense the office visit, but then the capacity to expand it in the meaningful ways, which are in the treatment and resolution of their disease.
That's actually a great point. So the answer is it's a much quicker interaction with the patient and doctor, the doctor and patient or provider. And then that information allows them to have more meaningful discussion about what is going on. And I understand why they don't know the word opioid, because that's not what the prescription says, right? So they don't know. So I don't think there's anybody, especially doctors, who have had to go through extensive education and time. I don't think I've met anybody that doesn't believe education is not a benefit to a patient. So if they had the time to do it in the exam room, they would. We're trying to help that part of the exam in the lobby.
Well, it seems like what you're doing is also creating for a solution for the fact that insurances are decreasing reimbursement, decreasing the amount of time a physician can spend with a patient. And so what you're doing, if I'm correct, is unlocking, extra capacity for that physician in that office visit.
Yeah, I mean, I think about it, like I said, I'm from the business side. So I think about it, if I have an NP that I'm paying X dollars, I want to maximize that time.
Yeah.
So the maximizing that person's time may be efficiency of time they spend with the patient. That's one of the things we provide. And then the economic return for that time is valuable.
Yeah.
So we do, it's a billable code, Medicare. We have basically 3 simple CPT codes, whether it's commercial Medicare or Medicaid, and workers' comp as well. So they can use that, go about their day, know that they've done better for the patient and better for the practice.
Yeah, that's wonderful. So if a provider is, hearing us talk about this and interested in getting started with Heal Clinical, what's that first step like?
First step is probably go to www.heal clinical, and that's spelled HEAL, not the other way.
Yeah.
So
on our feet.
Yeah, exactly. So Heal Clinical, and visit there, and they can go and see kind of what we do. And I'm happy to talk to anybody. My phone rings, as unfortunately I just ruined our interview because my phone rang, but I always answer if it's family. So, but I'm happy to talk to any of them. They can talk to our other doctors that use the system. We highly recommend that as well, because you don't want to listen to me.
Yeah.
I'm a sales guy.
How many clinics are you in across the U.S.?
Right now, we have signed in the last 9 months, we're at around 75 contracted clinics. And we are growing about 5 to 7 clinics every single month.
Well, congratulations. What you're doing is really creating better solutions for patients. And that's something to be admired.
I guess number one, it's patient, number one, everything is patient care based.
Yeah.
Number two is the doctor's got to get paid for their component. And if I can reduce the risk to my liability as well as a bonus, why not? Both for the patient and for the clinic.
Well, and to where we started the interview, right? If you can reduce not just the risk for the provider, but the risk to the patient and their family.
Yeah.
I mean, what a really beautiful way to honor your nephew.
Yeah.
So,
we'll try to do something positive about it, and I'll stay here as long as I can.
Awesome. Well, Tim, thank you for being here in studio with me. You heard it, healclinical.com. Check them out on the web, and let's get you in, 10 to 15 to 25 clinics a month.
Okay, that's a great idea.
All right.
Thanks, Kat.